Good morning, everyone. Thank you for joining PHCA for today's webinar, Reducing and Preventing Medication Errors in Assisted Living and Personal Care. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website later today. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey after the webinar. Your feedback is very important to us and to our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them. Now for today's webinar. Today's webinar is being presented by Wendy Mildner, President and owner of QRM Consulting. Medication use in the elderly has become increasingly complex over the years, with more residents residing in community settings taking 4 or more medications per day. Polypharmacy has had increased attention from Medicare and Medicaid. Medication errors are common, preventable, easy to make, and can be deadly to a resident. This webinar will review sources of errors, measures to reduce the likelihood of them occurring, and will discuss evidence-based prevention strategies. I'll now turn the webinar over to Wendy.
Good morning, everybody. Thank you for being here. As Wendy said, we're going to talk this morning about reducing and preventing medication errors in our communities. And my PowerPoint's not working. There we go. So the objectives for today are to identify some of the causes that we see of medication errors in community dwelling settings, describe some measures to reduce and prevent errors from occurring, and understand the importance of enhanced communication between our staff, our residents, and our physician groups. So just to talk a little bit about what a medication error actually is. It's defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. So that the healthcare professional would cover our nurses, our med techs in our communities. You'll see errors coming from patients that are doing their own medications, and the consumer would also be the resident. And this reference came from the National Coordinating Council for Medication Error Reporting and Prevention. So I wanted to talk a little bit about the 6 rights of medication administration. Now, these rights have actually expanded over the years, and you probably could end up finding 10 or more if you really kept digging. We started off in nursing with the 5 rights of medication, which those the right person, the right drug, right time, right dose, and right route. And over the years, the right documentation has been added in, and that would encompass things like, first of all, documenting that the medication was given, the time that it was given, especially for our as needed or our PRN medications. And then some other rights that have come up and have been acknowledged, I should say, over the years is the right to refuse medications. So residents do have the right to say, I don't want to take that medication. And the right to know what medications they are taking, which is why when we train our med tech staff to say, I have your blood pressure pill, I have your Lasix, I have your water pill, I have whatever it is I'm giving you, so that those residents can say, well, I don't take one of those pills. I would like to say that I think it would be wonderful if we had a magic wand and a crystal ball. The crystal ball could tell us when our staff were potentially in the process of making an error and we could catch it, or a magic wand to kind of stop everything and get it all back in line before something happens. Interestingly, in searching for some more recent statistics, it was very, very hard to find quality statistics that relate specifically to assisted living or personal care. It was going back to 2016, and the best statistics came prior to that in 2011. And to be quite honest with you, I don't find 2011 and 2016 statistics that helpful to us, because so many things have changed over these 3 to 8 years. But I will say to you that in looking at the literature, medication errors overall comprise about half of the assisted living violations in the country. And I think those of us in Pennsylvania would probably agree that we see more medication type errors in our communities than we see some of the other things, because these are the areas that they can focus in, and there are so many regulations that kind of cross over that even the slightest I not properly dotted ends up violating something in our regs. Preventable medical errors and medication errors fall into medical errors, is the third cause of death in the United States, and this is behind heart disease and cancer. And PharMerica now says that assisted living residents are taking an average of 12 to 14 medications per day. And if you've participated or observed a med pass in your buildings, you would probably see that your residents are taking more and more medications than they have in years past.
Wendy?
Yes?
Excuse me, I'm sorry. We're having audio problems. I'm not exactly sure what's happening, but it didn't say like I usually get a message, the broadcast is now going to start. So I think let's dial back in and try again. I'm sorry. Not sure why. I can hear you. You can hear me. Make sure that when you're dialing in that you, do the audio code or whatever. I'm not sure if that's it. But I didn't get the message that I usually get whenever you started. So,
all right, wait, hang on. Let's make sure I'm set up. Computer audio. All right, so you want me to log out and log back in?
Yeah. Let's try again.
All right.
Hey, everybody. Sorry about that. We're having some technical difficulties this morning. I think we're back up and running again, so thanks for your patience. Today's webinar is Reducing and Preventing Medication Errors in Assisted Living and Personal Care, and I will skip over the housekeeping stuff. Most of you have heard it. If you have any questions, just let me know. I'll go into today's webinar, which is being presented by Wendy Mildner, President and owner of QRM Consulting. Medication use in the elderly has become increasingly complex over the years, with most residents residing in community settings taking 4 or more medications per day. Polypharmacy has had increased attention from Medicare and Medicaid. Medication errors are common, preventable, easy to make, and can be deadly to a resident. This webinar will review sources of errors, measures to reduce the likelihood of them occurring, and will address evidence-based prevention strategies. I'll now turn the webinar over to Wendy.
Good morning. So can everybody hear now? Can we get a confirmation that you guys can hear me?
I'm having yeses. I'm hearing
okay.
That I can hear you now.
Okay, great. All right, trying to get this off my screen. There we go. All right, so this morning we're going to talk about reducing and preventing medication errors in our communities. Good grief. Our objectives today are to identify the causes of medication errors in community dwelling settings, to talk a little bit about some measures to reduce or prevent errors from occurring, and to understand the importance of enhanced communication between staff, residents, and physician practices. Medication errors are defined as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So healthcare professional in our settings would be either our nurses who are passing meds or our med techs. Over the years, the rights of medications have expanded, first starting at 5, now at 6, and as the years have gone on, additional rights have been identified. So the basic rights, the right person, the right drug, the right time, the right dose, and the right route. They've added in the right documentation, so whether that is charting that I gave it, when I gave a PRN, charting that I didn't give a medication for whatever reason. And some other rights are the right to refuse medications. So our residents do have the right to refuse medications, and the right to know what they are taking, which is why when we teach our med techs or anyone to pass meds in our communities, we should be teaching them to tell the resident, I have your blood pressure pill, I have your Lasix, I have your whatever it is that they are giving. Many of our residents, most of our residents know what medications they are on. They know they take 6 pills in the morning. And if you come with 7, they're going to look at you and say, what's number 7? They want to know, and they should know what it is they are taking. One of the things that I thought was it would just be really nice if we had a crystal ball that could show us when our staff were headed down the path of making an error or potentially making an error, so that we could kind of jump in there and fix it before it happens, and or a magic wand to kind of erase the whole processes and just start all over to help that staff person prevent making any kind of a medication error. The statistics in assisted living medication errors are really difficult to find. As you all know, that we don't have a central reporting data. We do have reporting to our states. And to be honest with you, that's if the community is reporting as they should be. There's a lot of information out there for long-term care medication errors, but not a ton for assisted living. And I was reviewing someone's doctoral project on reducing errors in one of the an assisted living out in California, and she had no baseline data as to the severity of medication errors in assisted living, probably because it's difficult to find. And the community she was working with in particular had no baseline statistics. The wellness director told her, yeah, I'm pretty sure that our people make errors, but they had no quantity or type of errors that were made. So it was interesting to look at her project and how she was able to decide whether she affected a change with that or not when she didn't have any baseline data to even start with. The most recent statistics I found were from 2016, and the best statistics were from even prior to that were from 2011. Medication errors comprised half of all AL violations is probably one of the biggest takeaways that I had from the literature. Preventable errors, medication errors fall into medical errors, is the 3rd cause of death in the United States behind heart disease and cancer. For America published something late in 2018 and mentioned that assisted living residents take an average of 12 to 14 medications per day. And if you have watched a medication pass in your buildings lately, you probably could concur that quite a few of your residents take large numbers of medications. When you add in things like vitamins and over-the-counters and supplements and all of the things that their families believe are going to help and cure them, they keep adding more and more things for the person to take. And I've seen over the years, residents are moving into our communities more chronically ill and more debilitated than in years past. They're staying home longer versus coming in healthier and younger. They're staying at home longer, they're sicker, they're saving their money for moving into facilities because of the expense. And so they're, as I said, they're coming in a lot more sick than they had in the years past. Some types of medication errors that we will find, I think, are the obvious ones are the ones that violate one of the 6 rights. So we gave the wrong dose or the wrong drug to the right patient. Maybe they were ordered 20 milligrams of Lasix and the pill came in 40 and somebody didn't cut it in half and they administered a higher dose. Or they gave a sound-alike drug to, a blood pressure medicine or something that sounded like another medication to the right resident. They went to administer meds to the right resident, but somewhere along the line popped the wrong pill or took the wrong pill from the bottle. They gave the wrong person someone else's medications. That happens when we don't have photo IDs in our medication administration records, when we're not asking our residents their names, even though that is not always a reliable measure, because sometimes residents don't remember their names, or they'll say, "Are you Sally Jones?" and that person just says yes, versus saying, "Could you please tell me your name?" I mean, our residents don't wear armbands. They don't wear any identifiers. So we really do have to rely on photo IDs, and we have to train our staff that even though you know who that resident is, you still need to verify through the picture. The wrong time. So medications that were given too close. Maybe they were PRN or as-needed medications that were due every 4 hours and somebody gave it in 3 or 2. Or we're giving meds with meals instead of before. There are a handful of those medications out there that need to be given before breakfast, which typically means about 30 minutes prior to eating a meal. And in some situations, there are other things that need to happen, such as the resident needs to stay in a seated position versus laying back down. So if we don't follow those rules and those orders, those are considered medication errors. The wrong route. Now, this is usually not an issue in our industry, but it can happen. I recently was listening to people talking about confused residents who got a hold of maybe a suppository and ate it versus allowing the nurse to give the suppository correctly. Omission. So a medication not given or not documented. If it's not documented, it wasn't done. So I think we see a lot of that happening in our assisted living personal care settings, that people are moving at a pretty fast pace and they don't chart everything that was given. And then transcription. How the order was noted incorrectly, how the order was taken off of the written physician order or the written prescription and put onto the medication administration record incorrectly. Some maybe not so obvious types of medication errors, allergy errors. We should be looking at residents' allergies every time we pass medications. It is possible that someone has become allergic to a medication or had some significant side effect to a medication that they have been using for a while, or we've introduced something else that has now caused an interaction. And sometimes the pharmacies are not catching it. It depends on how many pharmacies you're using, which is one of the things we'll talk about in a little bit later. Administering expired or discontinued medications. Those are also errors. Those come typically from not following the community's systems and processes for when a medication has been discontinued and properly noting that on the MAR all the way across the MAR so that no one can accidentally give that medication. and administering a medication that's been expired. Maybe that eye drop, the insulin pen, the insulin vial may be expired or outdated based upon the date that it was open. Monitoring errors, not taking the blood pressure or the pulse or the glucose test before administering medications. I was working with some students last week and we had to give a blood pressure pill, and I had to remind the student to really read that order because it did say hold if the blood pressure was less than this. And they were about ready to give that medication and had not checked to see that A, the vitals had been done, and B, what that blood pressure was. Some compliance errors. Residents that are not compliant with their own medication. Now, we're not going to be writing incident reports typically for residents that are self-administering meds and may be doing something wrong, or you may write one, which would be your impetus potentially to take over the medication administration on that resident. But if the resident is continually refusing or spitting it out and throwing it away, while you're not necessarily going to have to report that per se to the state as part of a medication error, you are going to want some degree of documentation so you can go back to the physician. The other compliance errors is staff not following the systems that you already have in place, and those end up resulting in errors. So maybe they're not passing meds with the MAR, or maybe they are pre-pouring medications and the day before, and a medication has subsequently been discontinued and they go to give that medication. And then reconciliation errors. So these would be discrepancies that we don't catch when that person comes back from the hospital or when they come back from a skilled to us, or maybe reconciliation not done. If you have a process in place by which your residents' medications are reconciled with what they went out on versus what they came back in on, and you're not following it, that would be considered an error. So some causes of errors, and I think, a lot of what we're going to talk about the rest of this time, there's no magic wand here. There's no magic secret sauce to fixing this. It's going to take persistence and having good systems and processes in place and following through and holding your staff accountable and training. Lack of adequate training is probably one of the biggest causes of errors. Were all of your staff properly trained on how to use an insulin pen? I know they all have to go through diabetic training, but were they also trained on the floor? Was their training follow through? Did your wellness director watch them herself, not just the trainer for the medications, but your wellness directors need to be checking on them and making sure that they have received the adequate training and they're following your systems and processes. Ongoing training. If you have things changing, is everybody getting trained and signed off by the trainer versus by word of mouth that, oh, we're doing this way now, and that person really didn't understand? Lack of monitoring processes, so observing staff. Second checks on some medications. Perhaps there are some medications in your community that you seem to have an issue with, and you want to implement. That takes two sets of eyes to look at that. And I know that in some cases where you only have one med tech in the building, that may be difficult, but anybody could actually look at that medication and go, yes, you only have a half a pill, or yes, you have 5 units of whatever of insulin in that syringe, or whatever that happens to be. Lack of documentation. So we're not monitoring what our staff are doing from a documentation perspective. One of the biggest causes of errors is not following systems and processes that you already have in place. Most of you probably have some very good systems and processes in place. And when you really start to look at your errors and do some root cause analysis, you're going to get to the point of seeing that perhaps your people aren't following those processes. I've been through audits, where surveyors have come in from different types of managed care and, from our state surveys, and they're going, you need better systems and processes in these areas. And when they actually have a chance to look at your policies, they go, no, your systems and processes are good. Your people just aren't following them. Distractions. This is also a big one. Most of us don't have somebody answering the phone in the morning in our communities at a front desk or in an office. And your med techs are usually the ones carrying the phones. And one of the biggest distractions is the phone ringing and them having to answer it for non-urgent or non-emergent things. A messy workspace. I know that probably might sound a little silly to some, but if you have Mars strewn all over the place and different packaging laying out and, cups in 5 different places, it really, lends them to be distracted and the potential to pick up something and give it to someone that was not meant for that resident. And then ambiguous or illegible orders. It's really important that you work with your physicians and your PAs and your nurse practitioners as best you can. And, that's where your wellness directors come in and get back on the phone with the doctor and clarify some orders and write them out in a format that makes a little more sense. Abbreviations and somebody reading the abbreviation a little bit differently. So that is another big area that, could result in errors. The consequences of errors, I think the obvious is harm to the resident, whether it's minor, whether it's major, whether it's a potential harm to the resident. Maybe somebody caught something, it was a near miss. You still need to be looking at those. While no error was made, you want that staff person to come to you and say, look, I want to tell you this just almost happened, and here's why I think it happened. Your staff turnover is also a consequence. You may have to fire people due to the types or the number of errors that they're having, or staff leaving and resigning due to their feelings surrounding errors. One thing I always tell nurses, you will make an error in your lifetime. I have made an error and I will never forget it. Fortunately, there was no harm to my patient and it was caught very quickly. But everybody has that potential to make an error, and it's how you support your med techs and your nurses if they do make an error, especially if it's a very serious error. And, because you lose your confidence, you lose your ability to, and you say things like, I don't know if I should be a nurse, or I don't know if I want to pass medications. And as the management, as the leadership, we have to kind of help them through this. I've had a med tech in the past made an error. It was not a good error. Fortunately, the resident wasn't majorly harmed, but it still was a bad error. And they wanted to throw in the towel and they wanted to give up. And, we supported them through this and pushed them back in through the med process and helped them by doing observations and assuring them they were okay. And this person is finishing up nursing school and has gone on to become an LPN. So, there are really good people out there who make errors and then want to quit or want to stop passing medications because they feel that they're a failure. Harm to your community, your reputation. If you're making a ton of errors in your building, that word is going to get out. Your staff are going to tell people. Your state surveyors aren't going to be telling people. Your ombudsman isn't going to be telling people. Your families are going to tell people, and then that is potentially going to affect your reputation. And then citations and penalties related to medication errors. It can and will affect your license. You may be placed on a provisional. They may turn around and say, we don't think you're safe anymore. We're pulling your license, and you're going to have to move out all of your residents. So why aren't errors reported? The number one reason errors aren't reported is because staff are afraid of getting in trouble. That is the biggest reason. And residents who do their own medications, they fear having their independence taken away. So they're in their apartment and they're self-administering their medications, and they take 2 blood pressure pills because they forgot that they took one this morning. And then you're finding them on the floor with a very low blood pressure, and you're sending them to the hospital. They don't want to tell you that they did that. So some interventions that we can put in place to help prevent these errors. First and foremost, you have to have a culture of safety in your organization. And you have to have buy-in from every level of the organization, your administrator, your care staff, your housekeeping. Your housekeepers see things that they can tell you, like your med tech left medications on the nightstand for Sally Jones to take. That is not how we pass medications in our buildings. They should not be leaving medications on the nightstand, because anybody could wander into that apartment and take those medications, and we wouldn't even know that that happened. So you want people reporting what they're seeing. You want to communicate your values and your expectations from the beginning of time of that person coming to work for you, so during onboarding, and then ongoing. Have a policy of sorts that is non-punitive. It encourages your staff to report their own errors. I had a family come to me one time and tell me that the staff person would not report their error because they knew they would get in trouble. Little did that family know we had a no discipline policy in our building. And that person would not have been written up for the type of error that they had. Now, if they had had repeats of those kind of errors, we probably would be looking at some counseling. Or if there was a major, I just didn't bother to follow the policy and now it resulted in an error, potentially that's going to result in discipline up to and including termination. But you wanted people to come and say, oh my goodness, I actually accidentally just gave Sally Jones Mary Jones's meds, so that we can get on that immediately. You want to simplify your systems and your processes and have them be standard across your shifts. Day shift shouldn't do something one way, and evening shouldn't do it a different way, and night shouldn't do it a totally different way. So, what kind of processes do you have in place for flagging medications that are changed? Processes to hold medications if something appears off with that resident, or it doesn't match what the packaging doesn't match what the MAR says. What are they following? Who are they going to? How many of your residents are seeing multiple prescribing doctors? What is your process to make sure that one physician, probably the PCP, is the one that is minding the overall patient to ensure that the medication combinations are safe? It's the same things with the pharmacies. If you have a resident that is getting medications from Walgreens and CVS and through their mail order and some through your house pharmacy, one pharmacy has got to be responsible for looking at all of those medications and going, well, this medication is going to interfere with that medication, or there's a bad reaction potential here. Medications not available should be a never, never, never event. So what is your process, your system for making sure your medications are there? One of the things that I've implemented in my buildings has been, in Pennsylvania, since we have to do our medication orders every 6 months by way of regulation, then I have my nurses and my med techs write on all the medications that are refillable, so that would not apply to your narcotics, times 5 refills. So every 6 months, your physician is signing off for 6 months of medications. The pharmacy is getting 6 months of medication orders. You should rarely have an issue with a medication not being available. The other thing that you want to do under your systems is make sure that you're educating your physicians where you can. And I know that's often easier said than done, but this is a great marketing opportunity for your communities to get out and do a little education to the physician groups and their offices on what orders coming into your community should look like. The Florida American Medical Association did a really nice education for all of their physicians on writing orders in an ALF, which I found really, really interesting. You want your staff to keep your carts and your workstations clean. Get your discontinued or expired medications out of the doors. I think we all can agree that we've probably all been cited for something accidentally being left in the cart. We've already talked about avoiding ambiguities, having prohibited abbreviations. QID 4 times a day could look like Q day with a period in it, depending upon who's writing it is. So, or QD, if somebody happened to put a period in there, could be taken off as QID, and now we're giving the resident 4 times a day medication versus 1 time a day. We've talked about legible orders. Involve your pharmacies in quarterly auditing of your carts and your orders. Have your staff know and follow exceptions. Have a do not crush list available. Have a list of medication in your MARS of specific timed meds, like those ones I said have to be given before breakfast. Have a current reference material available. Keep training your staff on new medications that maybe you are now seeing in your community that you haven't seen before. If there's changes in insulin pens or syringes, if you are getting people with IV lines and ports, there are people coming into personal care and assisted living with PICC lines. No, our staff are not responsible for those PICC lines, but people do come in with them. They need to know what they are and what happens if it falls out. And ports. Insulin pens are a really easy target for your surveyors because most of the time our staff, when they open them, do not keep the label with it and do not date the pen when it was opened and started to use. And we also see sharing, not so much of insulin pens, although I could see that happening, in an emergency and they can't find somebody's pen, but typically your glucometers is another area for the surveyors, especially here in Pennsylvania. Don't rely on memory. You want to have your staff following systems. They should check those medications 3 times before administering. That's how they're taught in their med tech classes. Minimize the med pass interruptions. And I know that's a little bit easier said than done. I used to send a letter periodically out to my families that said during these medication pass times, our front desk staff or whoever's answering the phone are going to be taking messages unless it is an emergency or extremely urgent, because we want them to focus. In some institutions, the med pass people are wearing special aprons that basically say, don't interrupt me, I'm passing medications. Follow your documentation best practices. Reconcile meds. When residents come back from the hospital or skilled, take the list that they had that they went out with. So let's say they went out with 5 medications and one of them was Lasix. When they came back from the skilled, they came back on 6 medications, but one of them wasn't Lasix. You want to point out to the physician, your patient went out on Lasix 40, but did not come back on that medication. Do you still want them on Lasix? Because the last thing you want happening is that person comes back into your building and you didn't reconcile, and 3 days later they're in congestive heart failure and you're sending them back out. There goes your rehospitalization rate. And you have a resident that probably could have been prevented. Make sure you're using generic and brand names on your MARS to reduce any confusion. I'm a really old nurse. There are still some medications out there that I don't know by their generic name or vice versa. But if you had both names on there, chances are I'm going to know both. If not, I can Google it. I can open my PDR. I can open my Lippincotts whatever it is, so that I could pull up so that before I give that medication, I know exactly what it is I'm giving. Make sure your PCP is aware of prescriptions by the specialist. You should have a process in place by, if they go out to the cardiologist, you fax that list to the physician of the new medications to say the cardiologist placed your resident on these 3 medications. This is for your records. Make sure your pharmacy has a full profile of medications, even if not filling. That's where you see a lot of your, what I want to say, errors coming from when you're working on your MARS and why nothing is matching. I had one community that never sent their VA orders to their pharmacy and then called me complaining that their pharmacy was not capturing their VA orders. Well, when we dug in a little bit to what their process was, we found out they weren't faxing the pharmacy the VA order. So if they don't know what they don't know. So just, if you're going to be using a pharmacy, a standard pharmacy in your community, and they're printing your MARS for you, make sure they know all of the medications that resident is on for profile only. But because their systems will also check for discrepancies or interactions, and some interactions with some medications can be lethal. EMAR. If you're not using an EMAR, you may want to consider it, but I will say to you, it may not be the end-all be-all solution to reducing your errors. You still have to have systems and processes in place, because I'm promising you, your staff will find workarounds. You still need to be consistent and diligent in your checks as the ED and as the wellness directors. One of the beauties is that it does often have built-in reference information. So most of the time there's some button that you can click to say, tell me what this medication is and what it does. Our nursing leaders need to be in the system every day. Buildings that I have had EMAR, that have had problems, you can always tell when the nurse has not been in the system, because the problems consist and continue. And again, staff will find workarounds to the system. Some quality improvement measures. The first one is training. Your CART and your MAR audits based upon a schedule. MAR should be checked every day by somebody. If it's not the wellness director, then maybe your night shift nurse or your night shift med tech. CARTs, probably at a minimum, should be checked once a week. And it's not a full CART audit. It's typically a top drawer, bottom drawer CART audit. I can go into a community and open the top drawer of their med cart and tell them typically within 5 minutes if they have a problem with medications in their carts and if they're going to potentially be looking at citations. Our nurse leaders need to be completing observations to anybody passing meds, whether it's a nurse or a med tech. Do not assume that your nurses are 100% accurate. I have seen more medication errors come out of nurses than I have with med techs in some buildings. Make sure that you're tracking your errors and errors by type. How many did you have that were just documentation errors? How many were wrong person? How many were wrong medication? And do root cause analysis on all of your errors. Our errors are best managed and prevented by analyzing and looking at our processes. Is it a process issue that we need to fix? Is everybody having a problem with this process? Is it just a matter of retraining, or does it need to be tweaked? Or is this a one-off, this staff person just decided that they were not going to follow the process? So, in conclusion, the best ways to prevent or avoid errors is to have very simple systems and processes in place and hold your staff accountable to follow them. Monitor their work, monitor the errors. Even remotely in my past position, I would be in the EMARs looking at holes in the MARS, medications not administered, medications administered over the 1 hour before or 1 hour after time frames, looking at documentation, lack of follow-up documentation. That is the beauty of having an EMAR. Complete root cause analysis whenever you do have errors, and be present in the process. Yesterday was speaking with somebody, they were talking about a couple nurse EDs that they had hired, and wanted to know why, of all places, those buildings were potentially having more issues in their wellness department compared to other parts of the building. And when you're looking at, the ED effectiveness, the wellness director effectiveness, et cetera, and I think one of the things is that, we often lay a lot of trust, as we should, in our wellness directors, but as EDs, we also have to be verifying that what they're doing and what they say they're doing is actually happening and things look the way that it is being presented. It's not that you don't trust them, you do trust them. But when the buck stops with you, when it comes to errors and problems going on in your community and occupancy, you need to be present in the process. You might not be a nurse, and that's fine, but you do know that there's a hole in the MAR if you pick up the medication record and you see something not documented in that box. So just being present, walking the building, it's amazing the things that you hear. Watching a med pass. You don't have to stay for the whole med pass, but watch a couple of people getting medications. Any questions?
Thanks, Wendy. That was really good information. Again, sorry about the technical difficulties we had early on. We will take any questions at this time, so type them into the questions box on the right hand of your screen, if you have any. And all good recommendations today, Wendy. That was really great information that you shared with us. Much appreciated.
I don't think there's any magic, any secret sauce. But sometimes it is just looking at things a little bit differently than what you're doing.
Always good reminders. All right. Not seeing any questions, but we'll just give it another minute. Don't forget to complete your survey that I'll mail out. I'll also include Wendy's contact information. So if you do think of anything afterwards or, at any point, if you have any questions as you get into those areas of medications, Wendy's available at any time for questions. And we do have a question. It is, according to DHS Medication Trainer Program, in order to observe and document, the nurse also has to be a trainer or a practicum observer, correct?
Mm-hmm. Okay, so yes and no. So in order to be compliant with the state's training sign-offs and the paperwork, yes, you should have a nurse that can be signed off as a practicum observer, and they just need to go through the MedTech class. There's I think it's chapters 7, 8, and 9, if I'm not mistaken. They go through that piece with whoever your trainer is, and then your trainer can sign them off as a practicum observer. However, you as the nurse or your nurse can do auditing and observing of their staff anytime according to your systems and processes. And if they come across any problems, then bring that to your trainer's attention, because perhaps the trainer's got to come back in and look at that employee. But just because you're not a practicum observer doesn't mean you still can't monitor and observe your staff passes.
Great. That was a good question. Thank you. Any other questions before we close the webinar for the day? All right. Don't forget our annual convention's coming up at the end of September. If you haven't already registered for it, the information is on our website. We hope to have more information coming out on that later this month with more specifics on the sessions. And also, don't forget, we have ongoing webinars. There are two, one later this month and one early September, and we're working on our fall schedule for the end of the year, October, November, and December. So keep an eye out for that information as it's updated. And I'm not seeing any more questions. So thank you, Wendy. We really appreciate your time today. And thanks again for bearing with us. Have a great day.
All right. Bye.